HCC. And as you will see, there is a considerable degree of overlap, and that is the problem with AFP. The area under the receiver operating curve is 0.8 to 0.85, which says it's a pretty good marker. About 15 to 25% of patients with HCC don't actually make AFP. They are a separate clinical subgroup, and they survive, those without AFP, considerably longer than those with APP. And you can see in this diagram, the median survival is nearly 2.5 years in AFP negative patients and 16 months in AFP positive patients. So the main limitation of using AFP as an HCC biomarker is its limited specificity. And the next slides show how we can overcome some of this limited specificity. So here are some large cohorts of patients. On the left, you can see AFP and then two additional biomarkers, DCP and L3, and I'll show you what they are in a minute. But the important thing to notice from this is that although AFP levels in the dark blue are elevated more in the patients with HCC, there is also considerable overlap with patients with chronic liver disease. On the right, you can see the receiver operator curve. Remember that if a tumor marker is absolutely perfect, then the line will go vertically up to 100 and then horizontally across, and that would give 100% perfect tumor marker. This shows the three biomarkers that we have used, AFP and then two additional biomarkers. So the area under the curve for AFP is 0.88, for DCP is 0.9, and for L3 is 0.84. So the idea is to take AFP, add in these two AFP additional biomarkers, L3, which is an isoform of AFP, and des-carboxyprothrombin. All three of them have reasonable area under the ROC curves. So we add these together and we come up with a score that is called GALAD. And GALAD stands for gender, age, and then the three biomarkers, AFP-L3, alpha-fetoprotein, and des-carboxyprothrombin. And if you have all these five, you can put them into this score, and that will give you a value which will tell you the likelihood that HCC is present in a particular patient. We use very rigorous statistical methodology that treats variables in their continuous form, and then it's been very extensively validated internally and externally. And if you want to see the original paper, there it is. So just to summarize this, we take AFP with limited specificity and we add two biomarkers, L3 and DCP, in order to increase the specificity. So here's the three biomarkers you've seen before, all looking quite good. When we apply the model, the thick blue line, you can see that there's quite a dramatic improvement. Up from about 0.8 to 0.97. Now, to apply this looks a bit frightening, this formula, but you don't need to do that because on the web, there are many apps that can do it for you. And I've just shown you here one such app where you fill in gender, age, AFP, L3 and DCP. And I put in, for example, here, a man age 75 with an AFP of 50 and 500 and a DCP of 10. And it reads out a score, and that tells you that there's nearly 100% likelihood of this liver having an HCC in it. The most important validation came from the United States, and this was a collaborative study from several major liver centers in the United States. And I've just pulled out here some of their conclusions. On completely independent data from the United States, they confirmed our original results. They showed that it was better than ultrasound. It was very good in picking up early HCC, including tumors with a negative AFP, and it wasn't affected by gender, age, etiology, or severity of liver dysfunction. And there's the ROC curves, very similar to what we showed in the original paper. And their final conclusion was that the outstanding performance of the GALAD score was confirmed in an independent multi-center US cohort of early HCC patients. So it looks good. What about surveillance? So we need to take a small detour here to talk about surveillance for HCC. The clinical perception is that big HCCs are incurable and fatal. However, small HCCs, by which we mean usually less than 3 centimeters, can be cured by surgery, transplant, or radiofrequency ablation. So if screening can deliver early HCC, the prognosis should be improved. That's the clinical perception. The epidemiological perception is that the aim of screening is to decrease disease-specific mortality. So how well can we do? So the aim of surveillance is to reduce disease-specific mortality from HCC. Who do we do it in? High-risk patients, usually patients with cirrhosis. What's the method we use? Ultrasound examination. And when do we do the ultrasound examinations? Approximately every 6 months. We should put in a big caveat here that surveillance classically should only be undertaken after a randomized controlled clinical trial has confirmed its effectiveness. There has been a randomized trial a long time ago in China. They looked at the results in 18,000 patients, half of whom were screened, half of whom were not screened. And the mortality, you can see, was 82 in the screened patients and 131 in those who weren't screened. It's an old study. The Western researchers have found numerous problems and issues with this study. But although they have complained about it, it's very evident that nobody in the West has ever done any better. People have talked about doing randomized trials of surveillance for HCC for 50 years, and nobody has actually managed to do it. So if we can't do a randomized trial, we have to make the best use of any evidence that we have. And here's a study looking at screening in patients with hepatitis C. And the authors conclude that ultrasound screening for HCC patients who are HCV positive does improve survival and emphasizes the crucial role of screening effectiveness. Another study, early detection and treatment of survival rates on people undergoing surveillance. It's a meta-analysis. And again, the authors conclude that HCC surveillance is associated with significant improvements in early tumor detection receipt of curative therapy, and overall survival. So there is not definitive evidence by way of a randomized trial, but there's good circumstantial evidence that surveillance is good. So the question that arises is, does adding a biomarker to ultrasound alone actually improve survival? And this study came fairly recently, looking at whether or not adding AFP to ultrasound was beneficial. So the sensitivity of ultrasound alone was 45%. That means that ultrasound picks up less than half of all HCCs. But the crucial observation is that the sensitivity of ultrasound when you add AFP goes up to more than 60%. So what's the problem with ultrasound? Why is its sensitivity so low? And the answer is probably that in most cases, the ultrasonographer finds it very difficult to get a good look at the liver because so many patients with chronic liver disease have severely fibrotic livers and are obese. And so in this study from Canada, you can see that less than 10% of patients undergoing surveillance actually had a good view of the liver. Others had poor, and it was only a fair view in 3/4. So big problems for ultrasound, but if you add AFP, it looks valuable. So the current guidelines recommend ultrasound with or without AFP. Future guidelines look as though it's going to become a standard recommendation to do ultrasound and AFP in HCC surveillance. What about liver function in HCC? As you will all know very well, we use Child-Pugh score to assess liver function. It's important to recognize the limitations. So Child-Pugh, if you've forgotten, looks at bilirubin, albumin, INR, ascites, and hepatic encephalopathy, and scores each of these and then grades patients as A, B, or C. A is the best, C is the worst. This is from the original paper, and you can see that the score is now nearly 50 years old. There were no statistics at all in the original publication, and it actually came from a paper on transfection of the esophagus for bleeding esophageal varices, a procedure which isn't done anymore. So what's wrong with the Child-Pugh score? Well, certainly in the case that we're talking about today, HCC, Child-Pugh was never meant to be used in HCC. It was developed empirically, and that many of the factors in the Child-Pugh score, such as ascites and encephalopathy, are highly subjective and difficult to score consistently. And if you look in the literature, there are more than 30 different variations on the Child-Pugh score. So what we've done is just taken all these variables, undertaken a conventional multivariable analysis. And what we can show is that if you just use bilirubin and albumin as your biomarkers, then there's no need, you can get just as good a result without considering the clinical features. And this has led to the ALBI score. What it is, it's sometimes described as a new way of assessing liver function in HCC, but in fact, it's just a simplification of the old Child-Pugh score. And it only involves albumin and bilirubin, and hence it's called ALBI. The score can be readily translated into a grade, 1 for best function, 3 for worst function. So it's evidence-based on many patients, very objective, discriminatory, and it's been internationally validated in more than 500 studies and more than 100,000 patients. Important observation is that if you use Child-Pugh score, nearly everybody now, because the tumours are being picked up earlier, is actually Child-Pugh grade A. And so that it says in effect that most HCC tumours have a normal liver, implying that we don't take into account liver dysfunction when assessing stage or prognosis of HCC. However, if you use ALBI, you can show that there is indeed a broad range of liver dysfunction in patients who have Child-Pugh A, so it's much more sensitive. This is the original publication, and this was one suggesting that ALBI should replace the Child-Pugh classification. As I said, ALBI has been very extensively validated, and this is probably the most detailed one. It's done according to the various stages, BCLC classifications, people with early disease, intermediate disease, and advanced disease. And in each of these classes, ALBI has been shown to improve and be useful in the management. And you can look at these. But this slide summarizes very nicely all the relevant applications of the ALBI score. What about therapy? This slide shows what happens if you remove an HCC and you measure Gallad's score sequentially thereafter. So that's the Gallad score on the vertical axis, and this is time in years after resection. The blue are the patients who don't recur. The red are the patients who do recur. And as you can see, that in both the recurrers and the non-recurrers, there is a marked fall after resection. However, we can show that those where the Gallad score remains low or remains in the normal range are cured, whereas those where it starts to rise at 9 months are actually going to recur and eventually die. And what this graph tells you is that Gallad is reflective of tumor mass. So whatever therapy you're using, if you follow the Gallad score, you can monitor therapy, whatever treatment you're doing, be it chemotherapy, TACE, or whatever. Finally, what about prognosis? So to examine prognosis, what we do is we use what's called the Ballad model. Ballad adds ALBI and Gallad together to obtain prognosis. So here is Gallad, which I've shown you, 3 biomarkers plus age and gender. Here is ALBI, which is albumin and bilirubin. And when you put the two of them together, you get Ballad. And Ballad very accurately predicts survival after any form of treatment. And here's one example, survival according to a Ballad model. And there are 5 grades. And you can see that the good grade, the median survival is about 3 years, whereas in the poorest grade, the median survival is much less than 1 year. So this is a very useful model, very easy to apply. And there's the reference if you want to have a look at it. Finally, I've focused mainly on our own work, but there are several other models. In fact, the literature is teeming with models for diagnosis and monitoring of therapy. The important ones are the AMAP score, at the bottom here, and the HES score. The HES score from the States is called Early Detection Screening Algorithm, and it incorporates age, ALT, platelet counts, and a rate of AFP change. It's quite complicated to use, but it looks quite accurate. The other possibility that's come from China is the AMAP score, and this involves only age, gender, and the ALBI score and platelets. And again, here's the original paper, very clearly presented. So, conclusions. Despite several limitations, AFP remains the de facto definitive HCC biomarker for surveillance, management, and prognosis. It does have limitations in sensitivity, but as I hope we've shown you, that statistical models that combine other biomarkers or clinical or laboratory features can enhance its performance. Circulating cell-free DNA is likely to become important over the next decades, but its delivery in the routine clinical setting will be challenging. I hope I've given you an idea of the use of AFP and its related models in all aspects of HCC management. Thank you for your attention.
Thank you very much, Professor Philip Johnson, showing us the light on the use of alpha-fetoprotein. Alpha-fetoprotein we've been using in Asia for many years with the clinical surveillance and diagnosis of HCC. But as you have said, from the APASL or EASL, the alpha-fetoprotein has been removed from the diagnostic criteria. But your data are very clear. Ultrasound alone, ultrasound plus alpha-feto, that will be 63%. And moreover, Thomas Bird and the group, the Scottish data, were also very convincing that alpha-fetoprotein is still very useful. In our Myanmar guideline for the treatment of HCC, we have stated that although the Western associations have excluded the alpha-fetoprotein, we, according to our local experience and real-life experience, we are still very useful, and we still put in our guideline for the diagnosis and monitoring of HCC.
I think that's very true. It's very difficult for me to understand what the problem was. I suspect in today's atmosphere of translational research, alpha-fetoprotein doesn't fit well because it has no known function and it was discovered empirically. So that's probably why Western so-called experts don't use AFP or its related models. But I think the East has been much more receptive and has led the way in showing how valuable this strange protein is.
Yes,
make a comment?
like Professor Philip Johnson pointed out, the cell-free DNA, the tumor DNA, cell-free RNA, the biomarkers, those markers were very challenging and will take a few more years to be of practical use in the diagnosis or monitoring of HCC. And at this point of time, alpha-protein seems to be the only useful and biomarker for us.
Yes,
I think that's correct. I think that's correct. And I'm currently working with centers in Vietnam on the Stop HCC program, and samples across Asia and in Saudi Arabia will be collected in this program and stored, and will be very useful for the increasing experience of cell-free DNA.
Well, I think this is a very, yeah, Wayne, can I make a comment, Phil? This is George.
Yeah, sure.
Haven't
Hello,
seen you
George.
for a while. Yeah, so we're still, we really treasure your stay in Hong Kong, and we worked together for the preemptive therapy. I still remember. So nice to see you. Now, having said that, I think Phil make a very good comment, and Wayne also in echoing. I think the alpha-fetoproteins is still indispensable in our practice in Asia Pacific regions. Because a lot of the cases were detected by alpha-fetoprotein plus ultrasound. And in fact, one of the problems with all the biomarkers is people try to do it in a cross-sectional manner rather than in a longitudinal follow-up manner. And sometimes I think this is actually much more practical for us to make a diagnosis on early the hepatocellular carcinoma detections to improve the overall survival. And unfortunately, there is no such studies. As you pointed out, it is disappointing that most of this, you actually use the right term, the so-called expert. I really like the terms, you are bold. Well, they don't have a lot of experience in managing of patients with chronic liver diseases and to implement early liver cancer detections while they write the guidelines. And this is very unfortunate. And there is the lack of evidence, solid evidence, as you pointed out, using the randomized control study. There is no random RCT ever. And then some so-called experts comes in and telling you that this is not useful and that is useful. And I think this is completely wrong. And we as the Asia Pacific Society, we should be in a position, especially young people, rising star like Ashot is here, we really think of doing some real studies with proper RCT and with the experience and to see what is the best measures we need to serve our populations with a high risk of hepatocellular carcinoma, taking into considerations the incidence and mortality of HCC does not decrease in the past 20 years.
I think you're absolutely right. It's a strange situation. The problem is, if you're frank, the West, by which I mean Europe and United States, it's cultural, and they would prefer to have all the studies coming from Europe and the States. And I think a good example is what Japan has done. Japan has implemented screening in an excellent manner and shown dramatically improved outcomes.
Yes.
And the West tries to ignore this.
I think this is very bad because the disease burdens is in Asia Pacific, and I think that everyone in this panel see more patients with chronic liver disease with hepatocellular carcinomas than most of our colleagues, respectful colleagues, some of them in the rest of the world. SK is around. Wayne,
Professor Sagim Abbas has raised hands. Professor Abbas.
Yeah, Dr. Abbas from Karachi, Pakistan. Professor Johnson, what is the significance of alpha-fetoprotein L3? Because there have dropped alpha-fetoprotein L3 and they have made a new scoring, which is GUARD scoring. And this Alexis GUARD. And there are papers that if you drop alpha-fetoprotein L3, there's no change in the sensitivity or specificity if you combine only PIVCA or DCP with alpha-fetoprotein.
Okay, so that's an important. So just to be clear, what we're talking about, 2 or 3 companies took on Galad. The L in Galad, as you said, is L3. The problem is that L3 is technically very difficult to measure. And only the Japanese company, formerly known as Waco, had a good assay. This was unfortunate for companies that didn't have L3. it looks as though, and I think we can confirm this, if you drop L3, it doesn't make much difference. And so you end up with the GARD score, GAAD. And I think that's probably going to be true. But to be honest, just adding DCP to the combination of AFP, male and gender, gender and age, most of the model of GALAD is related to those three. And adding the DCP doesn't add a lot to it. But yes, if you're going to run the GALAD score, dropping the AFP L3 doesn't seem to make a lot of difference. You're quite right.
And my second question is that in the ROC curves that you showed in your first or second slide, the area under the curve was more for DCP than alpha-fetoprotein, which was 0.9 for DCP and 0.88 for alpha-fetoprotein, if I can recall.
You're quite right.
Why don't we adopt DCP as the primary biomarker rather than alpha-fetoprotein?
Very simply, that when you do the model, when you run the multivariable model, the combination comes out better. That's the only reason. But you could argue that DCP is probably the best. But again, we come back to the same issue that DCP is not widely measured.
Professor Sarim, would you like to make a few comments? Professor Sarim, are you there?
Yes. So I've just said that, yeah, I agree that dropping the L3 from GALAD doesn't make much difference to the performance.
Yeah, but in China, we measure a lot of the center measures all three. So it's they have their own assays, and I think that's but there is no evidence that the all three is better than the two of the three or the GALAD score. We've never seen this data.
Okay, so we are just about to publish this, and I can tell you the results. What we've done is we have taken the 5 values of the GALAD score, and we have looked at all the possible combinations. And if you use any 4 of them, you get almost identical results.
Right.
Technically or statistically, 5 is very slightly better in terms of the p-value. But in practical clinical terms, any 4 biomarkers are better than just AFP, age, and gender.
That's important.
Yeah.
The issues, as I mentioned, and I want to hear the discussions from the panel, that's the longitudinal data is always cross-sectional. And I think it's to see the follow-up and to see how the change is very important for us. And we can catch early liver cancer by doing that. I think that's, and I think if you're sitting in the clinic, that's what you do, isn't it? Yes.
You look at changes. That's the real world. However, when you're doing formal analysis, serial data is very difficult to put in to proper statistical analysis because patients don't come up to your clinics at very regular intervals. So you'll have one patient where you've got a value at time equals 0, and then 3 months later, and then the next patient you see will be 3 months to 15 months. So it's very difficult to put that clinical experience into a formal model. And I think that's why it's not been done very thoroughly.
That's a point. That's a point.
Any comments from the other panel members?
Prof. Johnson, I'm Guo Chao from Singapore. Yeah, may I ask you a question whether the delta of the change in the alpha fetoprotein give any significance in terms of diagnosis?
Delta.
Yeah, so if you look at the end, I showed you some other scores. So coming from the States is the so-called S score. And they have in that changes in AFP, the delta AFP. And there are studies from Italy looking at delta AFP. And I have no doubt that the sudden onset of a rise in AFP is very significant. But as I said in answer to the previous question, when we've tried to put rate of change of AFP into a formal statistical analysis, it actually proves very difficult because good data is not available. If you can do it, it would be a big contribution to the literature.
Well, thank you very much, Professor Philip Johnson. Now, Dr. Yu are going to present the clinical vignette.
Okay, thank you. I've enjoyed talking to you all.
Yeah, thank
Thank
you.
you very much. Dr. Yu is
So
Dr. Yu is basically, he's got his basic degree from Malaysia. Then he got postgraduate MRCP and the MSc medicine from Singapore. And Dr. Yu had 2 years training in the Tan Tock Seng Hospital. Then he also had under Professor Lin Shi Ming in Taiwan, Punjong, Changong Medical Hospital, and he is currently a senior consultant at the Tan Tock Seng Hospital. And Dr. Yu will be management of ACC Grand Round case vignette. Dr. Yu, please.
thank you very much, Prof. Kim, for your kind introduction, and I would like to thank APASL for giving me this learning opportunity. So I hope that this can be an interactive session because with all the experts around, perhaps you all can give, a perspective on this interesting case. So, so I have a case of a 70-year-old Chinese gentleman. He was actually a chronic hepatitis B at the E antigen negative phase on the long-term endocardial, and the virus is actually well suppressed. It was non-compensated liver cirrhosis at Child-Pugh score A, diagnosed back in 2013 when he was aged 62 years old. There's actually some evidence of clinical significance, portal hypertension with splenomegaly and imaging reported collaterals. And there was actual multiple liver regenerative nodules on interval surveillance, and his ECOG is 0. There's no other significant medical comorbidities. So on the find in June 2020, on the ultrasound, that we actually found an isoechoic rounded structure with a hypoechoic rim in the segment 8, sitting in between the right and middle hepatic vein, measuring about 2.8 centimeters without any internal vascularity. So we proceed with a CT scan, a few weeks later, and the CT scan reported a 3.2 centimeter lesion in the segment 8 with arterial enhancement with a contrast washout. And there's actually a mass effect and indents in the right hepatic vein. And the CT thorax has some sub-centimeter nodules, which was on the subsequent scan, was found as actually quite stable and is actually not significant. So we proceed to actually further characterize it using MRI level. And it was noted that the tumor is actually growing to 3.8 centimeter now. And the T1 and T2 shows actually heterogeneous hyperindex lesion with a heterogeneous enhancement with a capsular enhancement and delay enhancement seen within the lesion. And at the T1 image here, you can see that there's actually some hyperintensity within it. There's actually suggestive of a hemorrhage within it. So there's actually no IVC invasion. So my first question to the panelists is actually, this is actually another view of the MRI liver. So what do you see on the MI level, and what is actual diagnosis, differential diagnosis, and what would you do next? Yeah, Prof. Josh.
Yes. What is, I'm sorry, what is the alpha fetoprotein levels of this
The
patient?
alpha fetoprotein level is normal. Later I'll show it's a non-sequential.
Well, because the imaging picture is compatible with hepatocellular carcinoma. In our setting in Hong Kong, for these cases with normal alpha fetoprotein, we would go ahead to do a PET scan with the C11 acetate to see whether there is any pickups of the C11 acetate for these lesions. Because this could help us to really understand whether this is hepatocellular carcinoma. Usually we take 2 out of 3 as the diagnostic criteria for hepatocellular carcinoma. So without alpha fetoprotein with lesions, which is classical on the imaging, then maybe we should have the PET scan. That's what we would do.
Yeah. Okay. So thank you very much, Prof. George. So is there any other suggestion? So if there's none, we actually didn't proceed with a PET scan. But then let me actually bring everybody through what the radiologists described for the LIRADS, and for those actually the typical features for the HCC. This is just for a learning experience. There should be an arterial phase enhancement, and then it shouldn't be it should be a non-ring arterial enhancement, and it should have a non-peripheral washout. Presence of a capsule, and the size the larger it is actually more suggestive of the HCC. And if let's say there's actually interval growth, which is more than 50%, is actually more typical for a HCC. Now, of course, there's actually some other features that actually can assist radiologists or us to actually differentiate whether this could be a HCC or the other condition. But if I discussed with a radiologist, then the radiologist actually say that there's actually a presence of a necrosis within the lesion. And they think that it's actually not very typical for HCC, so they label it as let's say LRM. So LRM means that there's actually it can be probably malignant, but it can be also actually a non-HCC specific. So we discussed in the tumor board. And their differential is actually, it could be an atypical HCC, or it can be a cholangiocarcinoma, or the mix, or the metastasis, and even the squamous hemangioma. So they actually propose to actually proceed to actually screen for others primaries like OGD colonoscopy, which actually returns actually there's no malignancy in the GI tract. And there's actually a liver biopsy done, which actually proven actually as a hepatocellular carcinoma. So as well, we can see here in this case that there's actually some ring enhancement here. If I think there's actually in the capsule here, which is actually also not typical for the HCC. If you follow this diagram, this is actually for CUS, which actually characterizes the blood flow and also a perfusion pattern. If let's say there's actually an enhancement, depends on what kind of enhancement there's, then the HCC typically is actually the whole lesion will get enhanced. Cholangiocarcinoma, there's actually as a ring enhancement, and metastatic cancer also sometimes can present with a ring enhancement. So in the washout period, and typically HCC, cholangioCA, and also metastatic cancer also can have a hypo, the hyper-intense after the washout. So there's actually a reason why they actually recommend to proceed with liver biopsy. And this is actually the alpha fetoprotein is actually 2, then all the other cancer markers are actually normal, and the Child-Pugh score is actually A. And as what Prof. Johnson actually already taught us, that I think I will skip the subsequent, this few slides for the LB score. So because LB score, the scoring is actually grade 2. And this, if let's say we compare with the liver score, just to summarize what Prof. Johnson told us, that the LB score is actually more objective, just need the number of factors is actually 2, so the data deficit is actually low. So the Child-Pugh score, that is actually some subjectivity that actually involved. So as what have been published before, if you look at here for this HCC patient under resection, if you use a Child-Pugh score for the same patient, same group of patient, you cannot differentiate this survival as compared to you are using the LB score. So this is actually another example with lenvatinib, and if actually, I mean, there's a clear differentiation between the Child-Pugh score, I mean the 5 and then LB grade 1 and grade 2. So it's actually quite different. So based on all the information before, then what is actually your treatment recommendation? How do you actually suggest, I mean, we should actually proceed to actually treat the patient?
You have a solitary lesion, so you have to go for good liver function. So it's a resection or local ablations. So having said that, you do a needle biopsy, and which is not our practice here, because the needling, our surgeons will be very nervous of seeding the tumors, especially or you already showed it is hepatocellular carcinoma. But having said that, since it has already been done, I think we go for local ablation or surgical resection.
Okay, thank you very much, Prof. Josh. Prof. Sharma, you have something to say?
Yes, I will go for a feasibility for surgery, but I think its collaterals are there. So maybe because of the portal hypertension, the surgery is not feasible. If not, then yes, one can go for local regional therapy in the form of TACE or radiation therapy, SBRT.
Okay, thank you very much. So if you actually look at the BCLC staging and treatment strategy 2022, these patients, I mean, lesions actually categorized at the early. And if you actually follow the algorithm, it should be the resection, as what Prof. George had correctly mentioned just now. But the only problem is actually how should the surgical resection be performed? If we look at the lesions here, it's actually I mean, sitting at the plane of right and also left hepatic vein. So they can't actually really do the annulocation, means that they just remove the lesion there. So they really have to actually consider the extended right hepatectomy. So that comes with a problem, because if let's say you are going to do the extended right hepatectomy, then you have a problem of what is actually the remaining, I mean, the liver loop, whether it's actually sufficient to actually support the survival. So, to actually assess that, what is actually our next steps is actually we probably have to actually reassess the patient's remaining liver function. So what we did was actually we did the indocyanine retention rate at 15 minutes. So this actually shows as a 5.7%. If just for learning experiences, so I just do the further study on this ICG clearance. ICG clearance is actually, I mean, it actually shows that for the normal liver function, the percentage of ICG should remain after 15 minutes after the application of the ICG should be 0 to 10%. So it is actually an indicator of the sinusoid capillarization. If let's say you can see here under the electron microscope, the layer here there's actually a space here between the between the sinusoid here. So if let's say the liver is actually getting harder, then there's a formation of a tight junction. So if a formation tight junction, it means that it's actually have a polar liver function. In this previous study here, it shows that for those actually patients going for the hepatic resection, only this indocyanine green is actually have the significant differences if actually, as a factors that are affecting the survival. So, and further on, if let's say this ICGR 15 can also be incorporated into the algorithm for the surgeon to actually see what kind of a surgery is actually appropriate for the patient. For example, if actually ascites is actually under control, the second question to them is actually how high is the bilirubin. If the bilirubin is actually extremely high, it's actually you cannot actually do a surgery. And if let's say that it's actually at the intermediate, then they do the minimal kind of resection. It's just enough to remove the tumor. Or if let's say it's actually normal, then you can consider all the others, the surgery based on the ICGR-15. So, and we also need to actually know what is actually the future liver remnant, so the FLR. So we did the CT volumetry, and the volume, the residual volume to the standardized liver volume ratio is only 31.1%. So can I get all the prof to actually comment whether this is actually sufficient to actually proceed with liver resection?
You want me to comment, Professor Win?
Probably you are muted.
Oh, sorry, I've muted. Yes, Professor Lau, please comment, because we are not very
it's a very interesting case, a slight difficulty in management. It all depends on the surgeon's expertise and experience and confidence. In our locations, I think our surgeons we are very good. They will not do right hepatectomy. They can resect the tumors by doing a few segments and leave the major livers behind. But if you want to do a right hepatectomy and with the residual liver volumes of 31%, it's a little bit borderline. And maybe if that is the issue, so you can consider local ablations and to consider the patients for later maybe liver transplant, because these patients always run the risk of liver cancer recurrence. So my comments, it really depends, and especially this needs to be discussed stringently at the tumor board on how confident the surgeon is, and also the vasculatures involved in the resections with the details. You have all the CT angiograms and so on, so you can actually decide how much livers you should resect and how it could be done. And as I said, it all depends on the surgical expertise in the local regions, and also you have to discuss with the patients the options of management. It's not a straightforward liver resection, so you can do. So that's what will be our practice here in Hong Kong.
Okay, thank you.
I
Prof.
have one comment from Tatsuo Kanda from Japan. Professor, if you want to perform surgery for this tumor, before surgery, you may perform right portal vein thrombus, and then you can see the left lobe hypertrophy. Then you resect the tumor. I think you show the Imamura's paper. That's one Markucci criteria. If you can preserve the liver function, you can maybe you can do surgery.
Thank you, Prof. Ganda and Prof. George, for a very insightful discussion. So I actually share the subsequent few slides. So For the CT, I think CT and MR volumetry is actually quite accurate, and that's what we can see here. If I know it's actually some conversion of results actually necessary, but then as what you can see here, the correlation between the actual liver volume and also the prediction by the CT scan and also MRI based volumetry is actually rather similar. So and at the moment, it's just some updates that there's actually a convolutional neural network and the AI that actually can assist the radiologist to actually calculate the liver remnants. And there's actually only just a few outlier, and it's actually quite accurate, and it's actually very exciting that it's actually moving that way. So they can even actually calculate the hepatic MRI PDFF based on the algorithm. So for the partial hepatectomy in mice, if actually one of the slides that actually my favorite slides is actually if let's say you resect more than 2/3 of hepatic mass is actually removed, then the liver regeneration is actually inhibited. Then we have to actually know that the base as a baseline, this liver is actually cirrhotic. So the 31% is actually less than 1/3, which is actually remaining. So it's actually the patients won't be able to survive if let's say we actually proceed with the surgery described. So it seems like the resection is actually out, as what Prof. George actually mentioned about whether it's actually a transplant and also whether we can actually do an ablation. And if let's say, now, when you actually consider ablation therapy in this case, and what would be the challenge? Is there anybody, would like to actually give a comment?
Well, I think that Professor Sheena, if he is here, would be the perfect person to really comment with the radiofrequency ablations on this tumor. It's difficult because of the vasculatures involved and positions of the tumor. But having said that, there are two ways: either you do a percutaneous or you do an open. And I think that in this case, you might consider open ultrasound-guided local ablations to control the disease. And then it's also a curative measures in a sense, but it has to be very precise. And then consider liver transplants for a cure of these patients.
Dr. Yu, could you,
Yes.
what do you think of this proton beam therapy in this particular case?
The proton beam, are you mentioning, Prof. Abbas, right? Are you referring to the proton embolization?
No, proton
The
beam.
proton
Beam
proton-
irradiations.
Oh, proton beam. We don't. Okay, sorry. So we don't have the service in Singapore. In my hospital at least lah. So we didn't actually consider the proton beam radiation. Yeah.
That has
So-
been practiced in India a lot. I think Chennai, also some centers, Apollo centers, they have a big proton beam center.
Yeah.
Yeah,
Okay.
can I make a comment, sir?
Yes.
So I
Yes.
think ablative procedure is a bit difficult because of the position of the tumor in between the middle and the right hepatic vein. So technically may be challenging for the intervention radiologist. I'm not the intervention radiologist. They have to take a call. For the purpose of radiation therapy, yes, it can be taken care with the proton therapy or a photon therapy as well, because the tumor size is very small. So one can target the tumor with a dose of about 40 to 50 gray in 5 fractions with minimum toxicity.
Okay. Thank you very much.
I'm a radiation oncologist at ILBS. So we are doing this type of treatment day in and day out.
Okay, thank you very much. So, as what Prof. Sharma actually correctly actually mentioned, if let's say it's actually a very deep-seated HCC, and also it's actually about 3.8 centimeter. It's more than the 3 centimeter that usually we describe for the complete ablation. So especially when we actually do the, when I learned some RFA from the Prof. Lynch, in Taiwan, and he usually is actually you use non-touch ablation, and then you probably also have to actually insert quite deep inside. Then it's actually very near to the IVC here. I discussed with radiologists, they think that is actually the probability of injury to the IVC, and also if you look at here, it's actually quite near to the heart and also the diaphragm. So they are actually a little bit concerned, and then especially with a heat sink, concern as well. So, but then nevertheless, you may actually want to actually ask whether the microwave ablation, which have a less heat sink effect, can be used in this case. And it's actually, for those, it's actually still efficient for the tumor volume less than 5 centimeter. So, however, because of the concern of a deep lesion, hard to get the margin, so they think that it is actually probably is not so. No, they're actually the not preferred option. So for us, actually a transplant for the cadaveric, it will be long wait list, and this patient have no suitable living donor. So essentially, we are all these options actually out, but then I just bring everybody through the flow. So now to actually extend a little bit challenge a bit of the therapeutic approach. I didn't actually discuss the proton beam here. I didn't actually prepare it, but then how about the taste? Because as what you can see here, Prof. Kudo have published before in the Apple consensus, if let's say for this patient is more than 3 centimeter, it's actually between 3 to 6 centimeter, then it is still considered as a good response to the taste subgroup. This is up to 7 criteria. So if you look at, there's actually some survival benefit as compared to the control for those actually, the with and also without the taste. But the problem is actually the taste for the HCC is actually even less than 2 centimeter. In 64% of lesion, tumors is still mainly persist in the area, especially at the extracapsular invasion and also satellite nodules. So even in the super selective kind of approach, it's still the 75%, the tumor necrosis is still remaining, 25%, so still having the viable tumor. So moving on, with this, we actually consider maybe we should do a radioembolization for the lesion. And this is actually what the multidisciplinary team decide. So probably use a Y90 radioembolization to the tumor, and then as what the Prof. Kanda actually mentioned, we subsequently have a right proton embolization. Then we repeat the imaging. Then we see that whether we can make the left liver become the bigger hypertrophy. Then from there, whether it's actually suitable for the surgical removal. So, and they did actually discuss whether this should be a single stage surgery or the double stage surgery. The double stage surgery is actually the ALPS. In the terminology is associating liver partition and portal vein ligation for stage hepatectomy. So, as what you can see here, after the procedure here, then with a repeat surveillance kind of monitoring of the CTTAP, then the tumor does actually shrunk to 2.5 centimeter in November. And after that, we repeat the CT volumetry, and then the future liver remnant is become 63.5%. And then we did further ICG retention of 15 minutes is 8.8%, which is still a good liver, reserve. Then on the 10th of December 2020, then we proceed with an open extended right hepatectomy, and they, of course, they say that they may not be able to actually remove it. Then they keep in view to an intraoperative microwave ablation. So from here, with this procedure, I mean, with a portal vein embolization, then with a hypertrophic left liver lobe, then we are able to actually proceed with, I mean, liver resection. And the patients actually went through the liver resection. Just some information on the portal vein embolization. The portal vein is embolized to redirect the blood flow to the, I mean, the left lobe here. This is actually, I mean, exactly what happened, I mean, to our patient. And after the 3 to 4 weeks, usually the remaining liver lobe here that will get hypertrophy to more than 30%, while and here they actually embolize it, then they partially to treat the tumor. So in the ALPS, it's actually a two-stage surgery whereby the patient have to go through the 2 times of a GA. It is actually less favorable because of higher mortality rate, about 10 to 15%, as according to my surgical, the colleague. So what they did is actually they make a slit here and then they ligate here. Then, but this approach will give you a very fast hypertrophy of the, remaining, the liver lobe. And then, the subsequent one, then you actually just remove, the disease lobe. Then the surgery is actually considered complete. Of course, there's actually other methods like simultaneous portal vein embolization and hepatic vein embolization, which can give a more rapid hypertrophy. So this is what published by my surgical colleague, that for the patients with colorectal liver metastasis managed by the ALPS procedure, and where the first stage they actually ligate the right portal vein, and subsequently after about the week later, I think this is actually a first stage. That you see is about 23%. After a week later, then become 38%. So that is actually always an option. Then some words about Y90. Until today, there's actually no consensus as what to actually the optimal use, even though we know that it's actually better than TACE and it's actually relatively safe. What happened to our patient here, to my patients actually, as what you can see here, 1 month after the Y90, the tumors actually there's still some viable tissue at the periphery. And after the extended right hepatectomy, subsequently, he's actually disease-free. And I last saw him in February this year. He's still remaining disease-free, and this is actually the left lobe is actually nicely hypertrophic. So my take-home message here is actually there's actually a new concept of treatment stage migration. And then this treatment stage migration have to take into a specific patient's profile, like their age, their comorbidities, even their, it's what Prof. George already told us, that the patient's value and the availability of the service that you have. So all this will induce a shift in the recommendation to the option that what could be considered priority for moving for a more advanced disease stage. And a multidisciplinary team discussion is extremely important. They could bring a better decision-making to improve the survival for HESIS patient. Okay, then you have to actually considering the expertise in the respective specialty in the institution. So I would like to extend my acknowledgement to my surgical and also radiological colleague. Okay, thank you very much. Yeah, is there actually any question or any further discussion?
Do you consider adjuvant therapy?
Adjuvant therapy as in using a systemic therapy to downstage or what? Yeah.
After the surgery.
Yes. Prof, we didn't actually consider adjuvant therapy because when we monitor using the serial scan, the disease actually seems to be actually confined to localized.
Any other comments or questions from the panelists? If not, I would like to close this session. I would like to express my sincere thanks to Dr. Yu for nice presentation of the Glasgow ACC real-life experience and all the pros and cons for any surgery or post-surgery and these things. And also Professor Philip Johnson for your kind presentation on the biomarkers, and Professor Abbas, Professor Tasukena, and other panelists, Professor Lau, for your presentation. And I must say, this 12th session of the LCAP series is also a very successful one, very informative, very educational. And we are going to look forward to see the 13th series section. We are coming to a close. LCAP is coming to a close. Thank you very much all. And Secretariat will leave.
Thank you, Professor. So we have completed today 1 year. This is the 12th session. So hopefully there will be more. And this is a fixed on every month, second Tuesday. So I request everyone to keep the calendar blocked for this. And we hope to see you in next month. Thank you.
Okay, Ashok, congratulations for being able to organize such a wonderful educational series. Thank you very much.
Thank you very much.
Izumi,
Thank
you organized very well.
Thank you, sir.
Thank you very much,
Thank you.
everybody.
Bye.
Bye-bye.
Bye.